Hi, I'm Dr. Francis Price, and this is a case of DSEK, Decimate Stripping Endothelial Keratoplasty. We're marking the cornea with a round blade called a trephine that we sometimes use to actually punch through the cornea, but in this case we're using it as a reference mark for where the new corneal tissue is going to go. In this particular surgery, we're going to remove a diseased inner layer of the cornea, Decimase membrane and dysfunctional endothelial cells, and replace it with a piece of donor tissue that has those same two layers, Decimase membrane and the endothelial cells, as well as part of the structural part of the cornea, the stroma. So we're going to first remove the attachments of the skin covering around the white of the eye, the conjunctiva. Use a little bit of cautery to control bleeding. And we'll make an incision about half thickness in this white tissue, the sclera. Now the purpose of this incision is to be able to put the tissue in the eye, but at the same time to actually be a self-sealing incision where we will not need to place any sutures. This has a number of advantages during the surgery, but postoperatively it also means that the patient has a much stronger eye and it will be more resistant to any type of injury and will also give them faster visual recovery. Now the first incision went about half thickness, and then we're going to make what we call a lamellar dissection, which just is a parallel incision to the surface, and we'll take that into the actual clear portion of the cornea. The idea is to make this long enough so that the natural pressure in the eye pushes the layers together, closing the wound. This also leads to faster visual recovery to have this type of incision instead of one with sutures. Well, we are now making an incision in the cornea. We're injecting some anesthetic solution to help decrease pain and discomfort in the eye during the procedure. And this surgery is being done under topical anesthesia. That means just eye drops and this little bit of anesthetic that we inject into the eye itself. We've now filled the anterior chamber with air, and air gives us the best contrast to see what's exactly going on when we go to remove the inner layer of the cornea. We're going along with a blunt instrument, a reverse Price-Sinski hook, and what this does is it breaks that inner layer. We've kind of outlined it along the mark that we had made earlier with our trephine. Typically for a surgery for DSEK, I'll make this outline a little bit smaller than what the outline was with the trephine. So there'll be some overlap between areas that are not stripped and with the donor tissue that we'll put in at the end. Now in many cases, especially Fuchs dystrophy, this inner layer has abnormalities on it that diffract the light and lead to a lot of distortion and aberrations in the way colors are seen and the way details are seen. It also leads to a large amount of glare and halos at night and distortion to the vision. In other cases, this inner layer can just have cells that aren't working properly, either because of old injuries, previous surgeries, difficulties that occurred with the eye, and they won't have those particular abnormalities on the inner layer that lead to the distortion of light. But due to the decreased number of the endothelial cells, we don't see proper clarity of the cornea. The cornea actually swells up and becomes swollen. We've now put a blue dye in the eye, and that will stain any loose areas of the membrane that we did not remove. It helps us identify those and remove those so they don't remain in place and potentially distort the vision post-operatively. We just expanded the main incision all the way to the inside of the eye. The previous portion where we made the calibrated cut into the stroma and the lamellar dissection did not actually enter the interior of the eye. So we've rinsed out the blue dye. There were no residual pieces of membrane that had to be removed. And this is the donor cornea, which has already been cut or sliced with an instrument called a microkeratome, separating the anterior 2/3 of the cornea from the posterior 1/3. We've just put a little viscoelastic on the cornea to protect it. And now we're going to carefully separate it with forceps, but we're doing this in a way not to touch the inner layer of endothelial cells, which would damage them. So we're separating these, and then we're going to pull it over onto a instrument called a boost and glide. The boost and glide actually curls the tissue as it's pulled into it. And we do this for a few reasons. One of the main reasons is so that when we actually introduce it into the eye, the inner layer of cells, the endothelial cells that we're very concerned about with the transplantation, are protected by having the rest of the tissue folded around it, and they're not damaged by shear stresses as the tissue is pulled through the incision. In this particular case, we're going to introduce the tissue into the eye by taking a needle, grasping the tip of the tissue, and basically pulling or pushing it into the eye. When it goes into the eye, it's still curled. We're going to inflate the interior of the eye, the anterior chamber, to get it to unfold. Once we get it to unfold, then we're going to inject air under it as we're doing here. Now we don't use any sutures to hold this donor cornea in place. The surface tension of the air does that. And then in this particular case, we're moving it over to the location that we want by stroking the surface of the eye with this roller. This is a specially designed knife that we're making small punctures in the patient's cornea down to the area where the donor graft is, and it's to drain fluid that's trapped between the donor and the recipient. Now, as I mentioned, the type of incision we used here, the scleral tunnel, doesn't require any sutures. And we're pulling the skin covering back and actually getting it to stick back in place by using cautery. So this has been a totally sutureless incision, except for the two sutures to hold the eye steady during the procedure. The black sutures you see below are utilized to stabilize the eye. We're checking the pressure in the eye, and one of the advantages of doing this topically is that we can ask the patient if they still see the light at the end of the case, and if they don't, we can lower the pressure. Thank you.